Rakesh, slides. Yeah, so I'm supposed to talk on a very common issue that we all face. A patient who comes to you with just a report of ultrasound showing fatty liver. So that's a very common encounter that most of us have now because a lot of patients are coming with routine checkups that they do and they just are concerned about the fatty liver that they find. So just an example, a 30-year-old or middle-aged male came for routine checkup, found to have fatty liver on ultrasound, and some of these might be having obesity or diabetes along with that. Some others might be having dyslipidemia, hypertension, or some other ASCVD risk factors. What is the usual approach of most of the family physicians in such cases? They advise the patients that it is with diabetes, control your diabetes well. If you are obese, lose your weight. And most often, we counsel the patient that it's a benign condition. It's very common. So let's not worry much about that. Just follow up after 6 months or a year and we'll repeat the scan again. Some of us also prescribe the patients drugs like UCDA or obeticholic acid. We'll just review in the next 15 minutes, is this the right approach or can we do something better? So I'll start the first slide with the pathophysiology and epidemiology of MASLD. We know that the basic pathophysiological defect in these patients is insulin resistance, and most of them also have obesity along with that. Obesity is a condition which is pro-inflammatory. Because of insulin resistance, these people have the uninhibited lipolysis from the adipose tissue because the inhibition of lipolysis, which is the action of insulin, is missing in these patients. And that is why there are large amounts of free fatty acids which are circulating in the blood. These free fatty acids, they go to the pancreas, they cause inflammation there, and we have hyperglycemia. Along with that, they also go to the liver, and in the liver they cause inflammation, which leads to steatosis and steatohepatitis, which is now called as MASLD or NFLD, and that also manifests as dyslipidemia or worsened glycemia. So we know that most of the patients, they also have this obesity, type 2 diabetes, and dyslipidemia along with this. What is the prevalence? The prevalence data varies from different studies because different definitions have been used. Even the nomenclature did not have a consensus till lately. And that is why the data, we cannot compare the different data from different studies. But in general, we can say that every fourth person has got MASLD or NFLD. The prevalence, this is a study which is looking at prevalence in India, and they showed that the southern Indians, they have a little higher prevalence of MASLD compared to the North Indians. These are the conditions which are often associated. As I earlier said, 90% of people do have obesity, around 70% have diabetes, hypertension, high triglycerides, and other components of metabolic syndrome, which are often seen in these patients. Female patients also might have polycystic ovarian syndrome. So this is the normal liver, and a person who is at risk of getting MASLD, they have large amount of free fatty acids circulating in the blood, they go to the liver, and we see deposition of fat starting in the liver. That is a stage where we call it as fatty liver, which is reported on the ultrasound by the radiologist. But this is a stage which was earlier called as NAFL, non-alcoholic fatty liver, also called as steatosis. Now, if this continues and if it is not treated on time, then some of these patients might progress to inflammation. So here you will have inflammation and hepatocyte ballooning, and at this stage we call this as steatohepatitis, or NASH was the earlier terminology used. Again, some of these patients, if you don't intervene on time, then they might progress to fibrosis. The patients might develop cirrhosis. Some of those might convert into hepatocellular carcinoma also. What are the rates of this conversion? So in general population, the conversion from NFLD to NASH and NASH to cirrhosis is just 10 to 20%. And from cirrhosis, around 3% of them might go to hepatocellular carcinoma stage, but the mortality is higher there. So 43% is the mortality in patients with hepatocellular carcinoma. Some of them might require liver transplant, and still there is a higher mortality. The worrisome problem is that the numbers are different if you talk about type 2 diabetic patients. Here the conversion from NFLD to NASH is 40%, from NASH to cirrhosis is 20 to 25%, the risk of SCC is 5%, and even the mortality is double than the non-diabetics, which is 85%. And that is why we have to be very careful, particularly in the patients of diabetes. If they come to you with a report saying fatty liver, you cannot just say that it's a benign condition. Now, this was a study where they compared the people who are diagnosed as NFLD, and among those who are having cardiometabolic risk factors and those who are not having. If you compare that, then you see that the people who are having other cardiometabolic risk factors, which are the components of metabolic syndrome, they have a significantly higher risk of CV events and fatal CV events, as well as all-cause mortality. And that is why it was realized that we should rename this condition. There are several causes for that, but recently these were the two meetings and two papers which happened. This was through a Delphi consensus, and they renamed this condition as metabolic dysfunction associated steatotic liver disease. The earlier name is not used anymore. So how do you diagnose this and how do you risk stratify? So as per these new consensus guidelines, it's a whole spectrum of steatotic liver disease. And in that spectrum, there are people who might be having other cardiometabolic risk factors. Those are the people we call them as MASLD if they do not have any other cause for this steatosis. There might be some other people who have the risk factors along with some other additional cause, like they might be having some consumption of alcohol. So then you call it as MAT ASLD. People who are having alcohol as the reason for the steatotic liver disease, you call it as alcohol associated steatotic liver disease. There might be some specific etiologies that you can identify. It might be drug related, it might be monogenic disease, or there might be miscellaneous causes. And if you can't identify a cause, then you label it as a cryptogenic SLD. So these cardiometabolic risk factors are very important, and if they are present, if you don't identify other cause, then you call the patient as having MASLD. These are the criteria. These are the same criteria that we used to use for defining metabolic syndrome: presence of type 2 diabetes, hypertriglyceridemia, low HDL, high blood pressure, obesity, generalized obesity or central obesity identified by BMI or waist circumference. So how do you approach a patient who has come with steatotic liver disease? First question is to ask whether the patient has got any of these cardiometabolic risk factors. If yes, then we see, are there additional risk factors? So if a person has only cardiometabolic risk factors, then you call it as MASLD. If they have some other additional cause, then it might be either MAT ALD, which is metabolic associated along with alcoholic liver disease, and otherwise it might be a combination etiology. Those who do not have these cardiometabolic criteria but still have steatosis on ultrasound, these people you have to look for the other causes. You might be able to identify some causes which might be alcoholic or drug induced, and if you can't find a cause, then you call it as a cryptogenic SLD. Now we'll focus more upon the MASLD, which is the topic for discussion today. So this is the slide from AAC workup. So these people, we know that most of them, they do have the comorbidities which are listed on this side. We have to rule out the secondary cause, and once you label a patient as MASLD, this patient is at dual risk. On one side, there is a risk of progression to cirrhosis, and on the other side, there is a risk of cardiovascular events also. So we have to take care of both of these. And for cardiovascular risk reduction, we need to look for these comorbidities and manage them well so that we can prevent the cardiovascular events in these patients. For prevention of cirrhosis, we first risk stratify the patient and divide them into three categories: low risk, intermediate risk, and high risk, and that can be easily done by the FIB-4 score. So for FIB-4 score, we require only 4 parameters, which are AST, ALT, platelet count, and age. Once you have these 4 parameters, which most of the patients come to you with the report, then you go for this calculator, which is available online as well as on mobile apps, put up these 4 values, and you get a value of FIB-4 score. Based on this FIB-4 score, if the FIB-4 score is less than 1.3, the patient is at low risk, and you can just follow up the patient for regular follow-up. If the FIB-4 score is more than 2.67, it's a high risk patient, and the risk of cirrhosis is even higher if the patient has got these risk factors like T2D, age more than 50, higher BMI, and so on. So these patients can better be referred to a specialist who deals with such patients. Now there can be a category of patients who are having a risk between FIB-4 between these two values, 1.3 to 2.67. So these are the people who are having intermediate risk of progression to fibrosis. For these people, we need to go for a second test. In our case, most of the times we go for fibroscan or liver stiffness measurement by elastography. So with that, then you get the 2 parameters which measure the stiffness as well as the fat content in the liver, and based on that results, then you again divide the patients into 2 categories: low risk, they can be asked for the lifestyle modification and routine follow-up. High risk and intermediate risk, you have to refer the patients to a person who is dealing with such patients. Now we'll come to management. So management, I'll talk about different drugs and different studies that have been done, but the conclusion is that weight loss is the best therapy. Weight loss works the best for these patients. This was a study which was done in 293 biopsy proven cases. So to do biopsy of liver is also difficult, and such studies are definitely reliable. So these are all biopsy proven NASH patients, and they were given only lifestyle intervention for 52 weeks for weight loss. So here you can see that patients who did not have any fibrosis at baseline, most of them, they got stabilized. And even among the patients who were having baseline fibrosis, if you lose more than 10%, you get benefits even in terms of reversal of fibrosis also. This is an Indian study in which they enrolled 60 obese Indian people, and they were again having biopsy proven disease, and they were advised regular exercise for 30 minutes a day and calorie restricted diet, and then they were followed up again. The changes after intervention in their body mass index, waist circumference, ALT/AST values, HOMA-IR, and NASH score are all significantly improved after the intervention of lifestyle measures. There are so many other studies. I just hit the slide for the shortage of time. Overall, they all conclude that in these patients, if you can achieve a weight loss of 5%, you get benefits: NASH resolution, fibrosis regression, steatosis improvement. If you can get a weight loss of more than 10%, then the benefits are significant. Even you can see a fibrosis regression in 81% patients, resolution of NASH in 90% patients, steatosis improvement in 100% patients. So more than 10% weight loss should be the goal for these people, but people who actually achieve it is only 10%. The last row is of the people who can achieve the weight loss of more than 10%. Now, this is a study in which they looked at meta-analysis of 32 cohort studies where bariatric surgery was done in patients who had biopsy-proven NASH, and they have shown that overall there was steatosis improvement in 66% patients, inflammation went down in 50% patients, even fibrosis went down in 40% patients. So now, in addition to lifestyle measures and the bariatric surgery or the different bariatric options, what we have is pharmacotherapy, and there are several drug targets which are being tested for this. Now, this was a meta-analysis where it was published long back in 2010, I guess, and here they looked at the studies in which people were given thiazolidinediones, either Pio or Rosi, for the treatment of NASH, and it was found on the forest plot that on the parameters like steatosis improvement and overall the glitazone arm was doing better, except the fibrosis regression. So patients who had fibrosis, you did not get much of benefits, but otherwise it was beneficial. They again further analyzed it by excluding people who are having type 2 diabetes. So these are the people who were non-diabetic and still given glitazones. Here the benefits are even better. So even in the non-diabetic population with NASH, glitazones were found to be effective for lowering the steatosis, hepatosis ballooning, inflammation, and also fibrosis. This was a famous paper which was published in NEGM, where they did a study on 247 adults and they randomized them into Pio, vitamin E, and placebo arm, and these are the results. So both pioglitazone and vitamin E were found to reduce the liver enzymes. Insulin resistance went down in people who were on pioglitazone, but weight was increased in people who were on pioglitazone. Overall, the study concluded that both of them work very well. But if you analyze it further without including the people with diabetes, vitamin E was also found to be having benefits in terms of reversal of NASH and resolution of fibrosis also. Saroglitazar is a drug which is invented in India, and it was earlier given for type 2 diabetes as well as diabetic dyslipidemia. So here they did an analysis in patients where it was given for management of diabetic dyslipidemia, and they found that the benefits in terms of reduction of liver enzymes were significant, and even the LSM and CAP score went down. So this was the result. Okay. So on all these parameters, this drug was found to be useful. So they did another study, and here they used biopsy, and again they found that the NFLD activity score improved in people who were given saroglitazar compared to placebo. So these are the other parameters which were analyzed as a secondary outcome, and I'll just run through the slides because there are studies with different drugs, other drugs also. This is a study with semaglutide, again a biopsy proven study where semaglutide was found to be very useful even in the reversal of fibrosis. This is a study with liraglutide, and again here the benefits were seen. And this is with dulaglutide, Indian study, DLIFT trial, again the similar benefits were seen. Now SGLT2 inhibitors, so empagliflozin, again there is data that it improves the liver fatness, and this is a meta-analysis where they found that it's not only empagliflozin but all the SGLT2 inhibitors, they have benefits in such patients. Elafibranor is again a dual agonist of PPAR receptors, alpha and delta. It also works like saroglitazar, and it has been found to be beneficial in reducing the NFLD score in these patients. Resmetirom is the new drug which has been approved by FDA, and it works through the thyroid hormone receptor beta selective agonist of this receptor, and this is a phase 3 trial which was done, and based on the results of this trial, the drug got approval for indication which is MASLD. So in this trial, they divided into three arms: placebo arm, resmetirom 80 mg, and 100 mg. And then these were the results. So NASH resolution without any worsening of fibrosis was significantly better among people who were given resmetirom 80 and 100 mg, and as well as fibrosis improvement by more than one stage was also significantly better in the people who were on resmetirom. In terms of safety data, the diarrhea and nausea were the common side effects. Other than that, there were no serious SAEs in this arm. So there are several other drugs which are in pipeline, but as of now, we only have this one drug which is approved for this indication. And the final the best therapy that remains is lifestyle modification and weight loss. So we should not ignore it as a benign condition. Screen all the patients who are at risk of having MSLD. Go by USG abdomen and liver enzymes. Then do the FIPS-4 score. If it is intermediate or high, then you go for elastography. Definitely manage the comorbidities first because those are very important. Vitamin E and pioglitazone has got some role. Other drugs like citalopram, GLP-1 agonist, SGLT inhibitors, they also have data. But the only drug which is approved for the indication is resmetirom. Thank you very much.